In Module 4, Part 2, we continue with our investigation of tests in the clinical chemistry section. In this section, we will review tests for organ function, cardiac, muscle damage, and lipids. These are the learning objectives for this module. So after reading the assigned readings and reviewing and reading the audio PowerPoint and other activities, you will be able to discuss the diagnostic use of bilirubin, blood urea nitrogen, creatinine, uric acid, and the lipids. You will also be able to discuss the analyte and purpose of markers of cardiac muscle damage. You'll be able to correlate common diagnostic tests related to organ function and the disease related, and apply the principles of patient and diagnostic data to interpreting case studies. It's important to consider the use or the big picture of the tests that we will discuss in this section. So we continue to talk about biomarkers for disease or risk of disease, tests that we use for screening for future disease risk, and we're also going to do a little bit of correlating with other common diagnostic tests such as CT, MRI, sonography. Those are all diagnostic imaging modalities, EKG, ECG, and nuclear medicine. So you will learn that the diagnosis of disease and the monitoring of disease progression involves the interdisciplinary work of multiple diagnostic modalities. The first biomarker that we'll talk about is bilirubin. So bilirubin is the result of the breakdown of hemoglobin, and you should remember the use or the function of hemoglobin from previous sections. Measuring bilirubin in the serum or plasma provides information about liver function, thus a picture of the liver on this slide. We may also see plasma increases in bilirubin due to hemolytic anemia, which is increased or excess red blood cell destruction. This should make sense to you because if bilirubin is a byproduct of the breakdown of hemoglobin, and hemolytic anemia or hemolysis of red blood cells produces more hemoglobin in the plasma, we will see excess bilirubin even when the liver function is normal. Essentially what happens is bilirubin is produced through the destruction of red blood cells. The liver conjugates or transforms that bilirubin so that it can be excreted in the GI tract. Excess bilirubin can result in plasma bilirubin increases and also bilirubin increases in the urine, and it depends a lot on what the source of the excess bilirubin is. So is it from liver function problems? Is it from a hemolytic anemia? Or is it possibly due to an obstruction such as gallbladder disease? The symptom of bilirubinemia is jaundice. So when a person is jaundiced, we observe a yellowing of their skin, their eyes, their mucous membranes, and also in urine and in their serum. What is measured clinically are bilirubin fractions, and these fractions can help the clinician identify the source of the excess bilirubin. So again, is it prehepatic or pre-liver? So that would be a case of excess red cell destruction. Is it due to liver disease, or is it a post-hepatic? So something that's happening after the liver, such again as in a gallbladder situation. Excess bilirubin can be very damaging to the developing brain. Babies are born with immature livers and in some cases are unable to process bilirubin properly, so we see them develop jaundice is called physiologic or neonatal jaundice. And here's a picture of an infant that is jaundiced, and also an example of an individual who has jaundice, and this person has a darker skin color, but the jaundice is demonstrated in their sclera of their eyes. So the excess bilirubin is damaging to the developing brain, and it can cause a condition called kernicterus. You can click on the picture here to view a little more information about kernicterus. Fortunately, bilirubin is light sensitive, which allows for the treatment of neonatal jaundice using phototherapy. So here's an individual, or a baby, who is being treated with phototherapy to treat neonatal jaundice and to prevent the accumulation of plasma bilirubin, which could lead to brain damage or kernicterus. The kidneys are vital organs, and kidney disease can be slowed but not reversed. Renal and urinary function can be affected by many problems. We consider the kidneys a filter for the blood, and so because blood flows extensively through the kidneys are directly linked to every other organ system. End-stage renal disease is a total loss of renal function, or the ability of the kidneys to filter toxins from the blood. And we also need to consider that diabetes, previously discussed, and hypertension are leading causes of kidney or renal failure. Creatinine is a biomarker that is measured as a demonstration of the filtering capacity of the kidney, and the glomerulus is the actual structure where blood is filtered and wastes are removed. Creatinine is a normal waste product of muscle mass destruction. It's a waste product of creatine phosphate. We say it's excreted solely by the kidney. So the kidney is the way that creatinine is removed from the plasma. And the other important thing is that for the most part, creatinine is not reabsorbed in the kidney. So again, it's a good measure of the ability of the nephron and the glomerulus to filter waste. Increased plasma creatinine tells us that we have decreased kidney function or glomerular filtration. So, along with issues that are related to disease like hypertension and diabetes, individuals do lose renal function as they age. We need to see about a 50% loss of renal function before plasma creatinine increases. So that tells you it's not a real sensitive indicator of early renal disease. And again, diabetes, impaired blood flow to the kidney, muscle wasting, hypertension, all of these can result in an increase in plasma creatinine. The reference range for plasma creatinine is quite low, 0.9 to 1.3 milligrams per deciliter. So small changes in measurement can indicate a fairly substantial change in the person's renal function. Blood urea nitrogen, or BUN, is another biomarker that helps give an indication of renal function. So urea is a breakdown product of protein metabolism, again used to measure glomerular filtration and renal disease. There's a word for increased blood urea nitrogen, and that is azotemia. If the function of the glomerulus, or the ability of the kidney to filter waste, depends on adequate blood flow through the kidney. It makes sense that an individual who is experiencing heart failure could also have elevations in BUN, or blood urea nitrogen. And the reason for that, as you should be able to put two and two together, is that if a person is in heart failure, they will be pumping less blood to all of their tissues, including through their kidneys, and the kidney will have less ability to filter waste. The normal BUN is 6 to 20 milligrams per deciliter, so you can see it's measured at a higher concentration than creatinine. Not as sensitive to renal function as the creatinine is, and again we do see higher numbers, higher normal numbers in older people, and again most frequently due to a decrease in blood flow through the kidney. It is common to see changes in biomarker normal ranges with age. Diagnosis of renal function, and this includes abnormalities in anatomy, blockages, damage to the renal system, are also generally evaluated with diagnostic imaging tests. So remember, in renal function we can have a number of things that can cause alterations, including obstructions or blockages, infections, disorders of the glomerulus, and ultimately renal failure. Contrast imaging, so what you see in this picture is an X-ray that is using contrast media. Contrast media is intended to make hollow structures more visible, and this particular test is called an intravenous pyelogram. So what has happened here is the individual has been injected with a radio-opaque substance. That radio-opaque substance, and you can see in the picture the white areas of the kidneys, the ureters, the bladder. That radio-opaque substance allows for visualization of the renal system. This is called contrast imaging. The IVP, or intravenous pyelogram, is a diagnostic test that helps identify abnormalities in anatomy, blockages, tumors, kidney stones. And you can learn more about this particular procedure from Radiology Info, and you should take the time to review this information. Uric acid is also a biomarker. Uric acid is the end product of purine metabolism. The term for elevations of uric acid in the blood is hyperuricemia. A condition that can be caused by hyperuricemia is gout. And gout is interesting because the majority of cases are what we call idiopathic. In other words, the cause is unknown. Some causes that are known to be related to gout are alcoholism, leukemia, and renal failure. Gout has been recognized for more than 2,000 years. It was often known as a rich man's disease because it was associated with wealthy people who were able to overindulge in rich food and alcohol. We know now that it's a complex disorder and can affect anyone. More than 2 million Americans each year are impacted by gout. It is treatable, and there are ways to keep it from recurring, including through diet. Hyperuricemia is characteristic of gout, although not everybody who has hyperuricemia has gout. Hyperuricemia, or elevations in uric acid, occur either because the person is unable to clear uric acid from their plasma through their kidneys, so this relates back to renal function, or the body is making too much uric acid. The image that you see is a radiograph, and you can see a cloud of swelling, an area of swelling that looks a little cloudy around the third finger, and within that cloudy swelling would be uric acid crystals. So it's possible to aspirate or remove some of that fluid and examine it microscopically for the presence of uric acid crystals. And of course, a blood test can also identify hyperuricemia. The next section will review enzymes. There are many enzymes active in the human body, and essentially enzymes are biological proteins with catalytic activities that promote chemical reactions in the body. Usually, elevations in plasma enzymes indicate tissue damage. Most are produced in small quantities, and most of the enzymatic action takes place within cells and in the blood. When enzymes are increased in the plasma, this does usually indicate cell death or destruction. Increases in certain enzymes can be linked to damage or injury in certain organs. We are going to focus on the enzymes used to monitor, or I should say measure and monitor damage to the cardiac muscle. But you should know that enzymes are also used to diagnose liver damage, pancreatic damage, and other types of organ damage. Before we go on, we should talk about just what is a heart attack, what causes damage to the tissue of the heart when a heart attack occurs. Pause the playback and take a few minutes to learn more about heart attacks. The accurate diagnosis of injury to cardiac muscle requires biomarkers that are sensitive and specific. CKMB, which is an isoenzyme of creatine kinase, and myoglobin, a protein that is found in all muscle tissue, were formerly included in a panel of biomarkers used to diagnose injury to cardiac muscle. Neither of these are currently recommended, mainly because of lack of specificity. So in other words, they could be elevated due to issues that are not related to cardiac muscle. Troponin, and highly sensitive troponin, is a protein. Troponin is a protein that is released from cardiac myocytes. The troponin test is sensitive, so identifies small amounts of troponin released from cardiac myocytes at an early stage in the heart attack or damage incident, and remains elevated for a period of time as long as 7 days, which allows for diagnosis of heart attacks that may have not been diagnosed at the time they occurred. So this sensitive and specific biomarker is the recommended test used for the diagnosis of damage to cardiac muscle. Brain natriuretic peptides, as mentioned previously, are used as a measure of injury to the cardiac muscle. The natriuretic peptide system is composed of 4 peptide hormones, each with a common 17 amino acid ring structure. They regulate blood pressure, electrolyte balance, and fluid volume. Unlike the other natriuretic peptides, the primary source of BNP is the cardiac ventricles. As the severity of heart failure increases, so does ventricular stretch in the amount of BNP in the patient's blood. Early diagnosis and treatment of heart failure are important factors in reducing morbidity and mortality associated with disease. Heart disease experts have hailed BNP as a powerful tool in the assessment of heart failure. Again, early diagnosis, reduction of morbidity and mortality. You can click on the picture here to learn more about congestive heart failure. Cardiovascular disease is the single leading cause of death and disability. Women suffer from cardiovascular disease just as much as men, just typically at a later stage. Although there have been great advances in the treatment of cardiovascular disease, it is still the #1 killer in America. You might be interested to know that approximately 30% of the disease occurs in individuals with no symptoms. Thus, the importance of having sensitive and specific diagnostic tests. As a quick review of the cardiovascular system, remember the heart supplies blood to all organs and tissues, pulmonary, coronary, and systemic circulation. The heart is basically a four-chambered pump with its own self-maintained electrical system. You can pause the playback and click on the picture for a review of cardiac function. Heart disease due to lipids from the deposition of lipids in the form of esterified cholesterol on the wall of the arteries is a significant cause of cardiac disease. Deposition starts as thin layers of fatty streaks, and fatty streaks can be seen in almost anyone who is over 15 years of age. Over time, these fatty streaks in the blood vessels develop into plaques, which can partially occlude blood flow. The lipid profile, in other words, the lipids that are typically measured when assessing somebody's lipid status, include triglyceride, total cholesterol, high-density lipoprotein cholesterol, low-density lipoprotein cholesterol, and very low-density lipoprotein cholesterol. Factors that play into the development of hypercholesterolemia and cholesterol plaques include hypertension, diabetes, smoking, hyperlipidemia, and you can see that this all becomes a vicious cycle that needs to be managed in order to reduce cardiac disease. Plaque is formed as a process of cell injury and repair. Small injuries occur in the vessel, which signals macrophages and platelets, which you should be familiar with from previous modules, to heal the break. Cholesterol is needed for membrane formation, and LDL, or low-density lipoprotein, brings cholesterol to the area. Continual injury and repair lead to the formation of more plaque and the narrowing of the blood vessel. The cross-section picture of a coronary artery shows sclerosis, which is most pronounced in the proximal artery, where blood flow is most turbulent. You can pause the playback and click on this picture to learn more about coronary artery disease. What is cholesterol? Cholesterol is a lipid. It's carried by the lipoproteins. 75% of lipoproteins are LDL and 25% are HDL. The reference range for total cholesterol is less than 200 milligrams per deciliter. You should know that this is a standard reference range that is employed by all laboratories and clinicians. We've talked previously about the importance of some tests being standardized so that a person who is tested and diagnosed in California will have the same kind of testing and diagnosis in New Jersey. You should know too that cholesterol has two sources. There is an endogenous or internal source. The liver is the major source and produces about 1,000 milligrams a day of cholesterol. The exogenous or external source is animal foods, essentially saturated fatty acids. The American Heart Association recommends limiting exogenous sources of cholesterol to less than 300 milligrams per day. Total cholesterol measurement includes the major fractions: HDL, LDL, and VLDL. Once again, it's important to note that a desirable total cholesterol level is less than 200 milligrams per deciliter. Total cholesterol levels are affected by diseases, by surgery, by myocardial infarcts, even posture and time of day. It is important to note, though, that total cholesterol is not affected by food from any single meal. Thus, individuals who have their cholesterol levels checked, say at a health screen, cannot minimize the impact of their elevated total cholesterol by saying that they had recently eaten. Diseases associated with cholesterol include those caused by elevated cholesterol, such as coronary artery disease resulting in angina, chest pain, and heart attack. But there are also diseases that cause cholesterol to be elevated. These are uncontrolled diabetes, hypothyroidism, and obesity. Diseases that cause elevated cholesterol then could be, and likely are, disorders that cause diseases such as coronary artery disease. We will briefly talk about the lipid fractions, or the important ones. LDL cholesterol is sometimes called bad cholesterol. The reason for this is it is the major cholesterol carrier. It drops cholesterol in the tissues of the body, causing buildup of plaque on arteries known as atherosclerosis. Often, LDL cholesterol is measured by calculation and not directly. The calculation involves measurement of total cholesterol, HDL cholesterol, and triglycerides, and then calculated. You should know that an increased LDL, low-density lipoprotein, equals an increased risk of coronary artery disease. Excess LDL causes coronary artery disease, but excess LDL can be caused by hypothyroidism, kidney and liver disease, and diabetes. A good reference range is less than 130 milligrams per deciliter. This, like total cholesterol, is a standard level. Lowering of LDL by 1% can result in a 2% decrease in the risk of coronary artery disease. So clearly, maintaining normal levels of LDL is important in reducing risk of heart attack and coronary artery disease. HDL then, high-density lipoprotein, is called the good cholesterol. It carries about only 25 to 33% of cholesterol, so is able to pick up cholesterol from the cells and take it back to the liver. In this case, increased levels of HDL are indicative of inverse risk of coronary artery disease. Decreased levels indicate a risk of coronary artery disease even when total cholesterol is normal. HDL is known as a negative risk factor. Thus, increasing HDL reduces the risk of coronary artery disease. A good reference range for HDL cholesterol is greater than 60 milligrams per deciliter. The higher the better in this case. HDL cholesterol or HDL reference range is also a standard reference range like LDL and total cholesterol. Triglycerides then, the last lipoprotein, are the chemical storage form of fat and in the body. So it's the storage form of unused calories. Triglycerides have an exogenous or external source and an endogenous source. And again, like cholesterol, the liver synthesizes triglycerides. Triglycerides circulate as chylomicrons, or lipid fractions, which have been recombined in the intestine. And if you've ever seen a specimen that is exhibiting triglyceridemia, or even a non-fasting specimen after a heavy meal, you'll see plasma that has a fat kind of the color of milk. Desirable levels of triglyceride are less than 150 milligrams per deciliter. Triglycerides, unlike cholesterol, are highly affected by recent meals, so don't have your cholesterol or your triglyceride tested after you eat at Taco Bell or McDonald's for lunch. Other tests for cardiac function include the echocardiogram. The echocardiogram is a non-invasive test, meaning nothing needs to be entered into the body, using sonography. This is a specialized area of sonography. Cardiac catheterization. This is a minimally invasive type of exam, which also uses imaging procedures to view the internal blood vessels and function of the heart. Cardiac catheterization can be diagnostic, but it can also be used to treat, such as an angioplasty. Other non-invasive tests are the EKG, the Holter monitor, and the stress test. All of these take advantage of the electrical conduction system of the heart to measure cardiac rhythms, and all of these are non-invasive.